probably never leave me. And it was not necessarily in my treatment, but in the treatment of somebody else that I observed. This is this person who's unable to speak. And she's, having that treatment. They have lasers, they have music going. And I think the whole office came in and started singing this song together to encourage her to be able to speak. And you just don't find that everywhere. That compassion for someone, and that the uniqueness to come and want to be a part of it and sing with joy and love, like that will probably never leave my mind. Like I honestly, I got goosebumps when I was watching it, and I thought, oh, God is most definitely present here.
So as a caregiver, you hold so much of their trauma in yourself. For me personally, I was trying to take his trauma, trying to take his pain, trying to take all of that into my own body so that he didn't have to feel that. And I thought that I had let it go, but until I sat with Dr. Jerry, I had not let go of it, obviously, because I still felt that tension in my body. But as soon as she did that to me, it was like a full release of just everything. And I let out a huge breath, and Jaden let out a huge breath at the exact same time that I did. We're so connected that if I let my trauma go from this situation, he'll feel that trauma leave his body too. And then he can feel the peace, then I think he has the opportunity to heal.
We have some new technology. This is SoftWave. I'm extremely excited about this for multiple reasons. We're one of the first clinics in the world to be using it for brain applications. I've had some firsthand experience on some amazing regenerative capacity with this machine on what it can do for the brain, restoring function extremely quickly, getting people out of pain faster than I've ever seen before. I've literally seen, even this week, I've seen primitive reflexes literally inhibit or integrate faster than I've ever seen before when we use it on the brain, but then also specifically for those primitive reflexes. We're the first to do it, that kind of application, which is really exciting. We'll continue to do some pilot studies. We're working in collaboration with SoftWave to do those research studies. So extremely excited. We're also using this now in combination with our B-cell procedure, using it before and after to help enhance the stem cells, which it is clinically proven, but also proven in the research to enhance, upregulate that stem cell response. So very excited about that.
I'm Kaitlyn, I'm the PT manager at Napa Center, and this is Erin Stranahan. She is the OT manager at Napa Center, and we're going to be diving into DMI. So the who, what, why of DMI, or otherwise known as dynamic movement intervention.
So first we'll tell you a little bit about where we work. We work at Napa Center, or Neurological and Physical Habilitation Center. We are a pediatric outpatient clinic. We offer weekly and intensive therapy sessions, and we take an interdisciplinary approach. We have OTs, PTs, and speech therapists who work collaboratively to maximize your child's development. Every therapist is empowered to take a global view of the child. Our PTs implement sensory strategies. OTs use our understanding of the musculoskeletal system to develop treatment plans. And our speech therapists are also comfortable in assessing motor skills to enable communication access and determine best seating options. We have 9 locations worldwide, soon to be 10. We have 6 clinics within the US. We have 3 Australian clinics and 1 in the UK. So dynamic movement intervention, or we will be continuing to call it DMI, is a specific set of exercises aimed at provoking postural control, strength, and motor skills to support acquisition of developmental skills. It capitalizes on neuroplasticity by introducing novel motor challenges. Oftentimes, our patient population requires increased input, whether that be more vestibular or proprioceptive input, to elicit a motor response. So if you've ever seen a clip of DMI, you might have observed the dynamic and unique exercises that DMI practices. It requires advanced training and is best applied under quality mentorship. And we'll be going into this and the following in more detail. So what we will be covering includes the definition, the indications, so who we treat, the precautions that we might need to be aware of, the goals, the theoretical foundations, the tenets of DMI, combined modalities that we use with this approach, the equipment, handling techniques. Kaitlyn's going to be going over some videos and give some descriptions and kind of let you guys know what is happening exactly in those videos and the training required to implement DMI. So what is DMI? This is the definition. DMI is a therapy technique used in physical and occupational therapy to treat children with motor delay by improving automatic postural responses and promoting progress towards developmental milestones. So as mentioned before, Kaitlyn is a PT, I'm an OT. We are both trained in DMI, and the training looks exactly the same. You just have to be an OT or a PT in order to practice and get certified in DMI. So the indications, the children diagnosed with any type of motor delay may be appropriate for DMI. They may start as early as 3 months, and it does require heavy manual handling by the therapist. Therefore, the child size, as kiddos get a little bit bigger, may play a factor into eligibility. We just want to make sure that we're being safe with our bodies and with the kids as well, because as we go into more detail, there are some exercises where we're kind of floating the kids in space, or we are going to be working further away from the center of the body. But the common diagnoses that we treat include cerebral palsy, Down syndrome, rare genetic disorders, metabolic disorders, spina bifida, spinal cord injuries, children with epilepsy, traumatic brain injuries, and acquired brain injuries. So there are some precautions, as mentioned before. Sometimes as kiddos get older, we just want to make sure that we're being safe. There are precautions for atlantoaxial instability for children with Down syndrome, children with abnormal tone, and ligamentous instability when completing exercises and holding below the elbow. A tenet of DMI is the progression to more distal or moving further away from the center of the body handling. This technique, while very effective, places increased load on joints, bones, and muscles. Therefore, children with low bone density or joint restrictions might be appropriate for more modalities, other modalities. A lot of the kiddos that we do treat do have lower bone density, so we're always mindful of that, and we just want to be cautious when we're practicing. Children with SPML or other muscle or tendon lengthening procedures might have some precautions as well. We want to wait till they're a little bit further post-op. Hip subluxation is considered when placing any torque on the hip in children who can't actively control the movement when facilitated below the knee or at the ankle. And children with osteogenesis imperfecta in moderate to severe cases should not be treated with DMI. However, mild cases, gentle exercise choices with extreme caution can be attempted. And we're always mindful of trachs and G-tubes so as not to dislodge them.
Okay, so the goals of DMI are to activate an automatic postural response, provoking an active motor response, and stimulating neuroplasticity. All right, so I'm going to go into a little bit of the theory. We'll try to simplify it as much as I can. And there's more information if you want to look into it more on our slides that you can kind of have access to. So the first theory is the neuronal group selection. The brain is an ensemble of cortical and subcortical systems, which are continuously organized into variable networks, the structure and function of which are selected by movement, so like motor output, and sensory input, so what's coming into the body. The units of selection are groups of strongly interconnected neurons called neuronal groups. These groups function as units that accept incoming information into the brain, and then they produce a desired behavioral or motor response. So this theory kind of postulates that unused neuronal groups will be pruned as a part of the normal maturation process, so essentially use it or lose it. There are two phases in this process. The primary phase, which is largely maturational and has limited influence on environmental variability. So it's more of that like non-purposeful movement. However, it links the brain to the rest of the body and creates neuronal formations such as like random kicking, swatting, and stretching movements. The secondary phase is the more adaptive phase of variability. So that this one becomes more environmentally specific as we create efficient motor function for each situation that arises. Individuals are able to adapt movements effectively to task-specific conditions or create motor solutions to novel conditions. So this one, like I said before, the environment takes more of a central role. So when the kiddos are presented with sensory information, the brain begins to have multiple solutions to the motor challenges and will choose from the right neuronal group that will be the most efficient to complete the task. Yes, so DMI helps to create new pathways and synapses by providing variable afferent information to correct movement patterns. So the next theory goes with the maturational theory. The maturational theory kind of indicates that development unfolds in like a fixed sequence. So head to foot, proximal, you'll hear us talking a lot about proximal to distal, and general to specific. So control is gained from the head downwards when the body is in a vertical position or vertical posture, such because your vestibular and ocular systems must operate from a stable reference plane in order to function effectively. Children will develop through predictable sequences at their own rate. DMI exercises generally follow head to toe, proximal hold that progresses to more distal hold. So when we move our hands more distally, we're requiring the child to control and complete more of the movements themselves, rather than us kind of working them through the movement. We will work on general symmetrical motor response to then more specific dissociated motor response. I know I feel that way about the theory too. So the last one is neuroplasticity. I'm sure you all have heard this word before. It's the ability of the brain to form and reorganize synaptic connections, especially in response to learning or an experience or following an injury. Neuroplasticity is stimulated by novel, challenging tasks. Without novelty and challenge, well-established habits will always dominate. So the aim of DMI is to facilitate the creation of pathways and synapses through novel motor challenges and the facilitation of desired movement patterns. DMI provides afferent information, so sensory information, to increase the repertoire of an affected individual's motor patterns. DMI works to stimulate the brain to maximize recovery potential in children with neurological damage or delay. DMI exercises work to revive dormant neuronal circuits. It works to decrease the disorganization or noise of the damaged brain and to prepare new active circuits to facilitate healthier gross motor function.
Okay, so now we'll go into the application or tenets of practice. So the first one being postural control. So postural control, we work on this by placing the child in a position to find correct alignment, whether that be exposing the child to gravity or placing them in anti-gravity positions. We work at the highest level of advanced skill. So when we work on a higher level skill, the child will make progress on the skills in between. So for example, maybe if a child isn't 4-point crawling, army crawling, we're still gonna work on standing, walking, and those higher level skills because that will also help with those other foundational skills such as creeping, rolling, etc. we work on those automatic responses, exposure to gravity, or use of reflexes. So automatic motor movements are developed in response to gravity. Movement is learned, however, we're not conscious of all the nuances of motor movements. So for example, we start to lose our balance, we shift our weight, our posture changes, however, we're often not conscious of that. So we're working on that with our children in order to get them to correct their balance, fix their alignment. If they're sitting, to help them regain their balance to the upright position. We place children in positions that exaggerate exposure to gravity with the expectation that a response is elicited. So for example, if we're doing a sitting transition, rather than having them, if we're not quite getting the response that we're looking for, laying them on a table, we might actually increase the gravitational load that they're getting by putting them on a decline, and that might help provide a stronger response. We provide sensory input, so we use input to facilitate regulation, modulation of sensory input, and to get an improved response. We used organized, purposeful, and sometimes strong sensory stimulation during these exercises. This helps to normalize atypical responses such as postural insecurity, gravitational insecurity, hyperresponsiveness to proprioceptive input, and we want to provide strong afferent messages to the brain. The handling techniques, as mentioned before, we often try to work proximal to distal. However, we're always trying to vary up our handling. So we also not only use our hands, we might also use some wraps, or the tool that we use is actually cabinet liner. And we use that to place, rather than using our hands, we can place those around the child's legs, around their pelvis, etc. We try to provide them with as much novel handling as possible, so they're not accommodating to a consistent handling technique, proximal to distal, and we're always focusing on the best alignment as possible with any of our handling techniques. So while we might try to work more distally, we also want to make sure that we are promoting optimal alignment, so our handling might change day to day. We provide dynamic stretching versus passive stretching. So we're actively moving the joints and muscles with specific motions targeting necessary muscle groups to increase the power, flexibility, and range of motion. So when a kiddo enters a session, we don't do any passive stretching, but we might start with exercises that involve bigger ranges of motion so that they're getting that nice dynamic stretch before moving into other exercises. We work on modulation of tone, spasticity, and reflex integration by providing exercises that are rich in proprioceptive and vestibular input. So we don't necessarily do reflex integration exercises, but a lot of the exercises that we work on, because they're so rich in sensory input, that's how we target those reflexes. And the outcomes that we get from DMI are a lot of gross motor development, fine motor development. So we're not sitting there. I'm an OT, we don't do seated fine motor or bimanual work. However, a lot of the kids make gains in their fine motor skills because they are getting so much strengthening to their proximal. We might do some upper extremity strengthening exercises, therefore they're going to gain greater fine motor abilities. Speech production, feeding, cognition, and attention. So sometimes we have families that are coming to us and maybe they're not doing a speech session, maybe they're just getting OT and PT, but they might find that their babbling increases, their number of words that they're saying has increased, and a lot of times that is because they're getting so much sensory information in addition to all of the trunk strengthening that they're gaining. And we also can utilize additional tools and modalities if we deem appropriate, and we'll go into that next. So we'll start with a brief overview of some of the tools and modalities that we offer at Napa Center and that we do utilize during our DMI sessions at times if appropriate. We'll have some time to dive into some, but not all the modalities, but our website does offer more information on all the modalities available if you want more information. And what we choose to use is based on patient presentation, diagnosis, and any precautions or contraindications that might make it safe or unsafe. So here is a list of some of the modalities that we'll use while treating DMI. We might choose just one of these or none of them, or we might do a combination of one or two of these additional modalities. So these include the Galileo whole body vibration plate, and I'll go into more detail about that. Theratogs, neuromuscular electrical stimulation, kinesiotape, therapeutic brushing, the therapeutic listening program, and use of blaze pods. So I'll talk a little bit about the whole body vibration plate, or WBV. It is a platform that offers side-to-side alternating movement very quickly. It transmits energy to the individual in standing, sitting, lying, or kneeling on the plate, causing the muscle to contract and relax many times per second, which mimics the tilt of the pelvis as it would during gait. The frequency, type of vibration, and variability are key components of the effectiveness. The vibration transmits energy to the body, causing to contract and relax. It provides contractions of the muscles that can exceed 1,500 times per minute, and it's used for stretching, strengthening, mobilization, depending on the frequency that's used, being either with frequencies range from 5 to 30 hertz. Depending upon the platform, the therapist is able to use the Galileo to address their therapeutic goals, which might include balance, stretching of tight muscles, spasticity reduction, etc. The next modality we might choose to use is NMES. These are adhesive electrodes which are placed on the skin above a targeted muscle or body part, and it has a unit which controls to change the settings or the switch. We generally use it for 20 to 40 minutes during a DMI session, and it's used to improve muscle function and strength, improve joint range of motion. And during DMI, if we choose to use NMES, we often use it on the lower extremities or the trunk. And the next one that we often utilize during DMI is the Theratog. So this is a compression garment. It consists of a top and shorts. It's attached and tightened with Velcro, and there is strapping to either mimic muscle contraction or to get better support for alignment. It can be worn for up to 12 hours a day and is often utilized during DMI sessions to promote optimal alignment. It does provide proprioceptive input and facilitation of alignment, and it can be funded through an orthotic provider or a private pay. And next, we'll talk a little bit about the equipment that we use. So we either have kiddos on a table if we're doing more developmental transitions, so it kind of looks like a massage table, or we have a set of wooden boxes that are either 6 to 4 inches tall, panels, cubes, beams, discs, squares, tubes, which is essentially PVC pipe, anti-slip, which is mentioned before, cabinet liner. We use balls, organza, which is like a slick, silky material, and we generally like kiddos to either be in supportive shoes. We really like Mimos or Piedro shoes, and some kiddos might use their AFOs if that's how they're going to have the best alignment.
Okay, so Erin kind of touched on this a little bit. I'm going to go specifically into the handling. So you'll see the therapist supporting at the legs, by thighs, below knees, ankles, or even one ankle. There are also handling techniques that incorporate the use of the anti-slip cabinet liner to give the child different input compared to hand contact from the therapist, just giving that variable input so that they can not kind of get used to it and adapt that way, always just creating new challenges. And support can also be applied at the top of the head or the occiput to promote alignment if a child is having a hard time with head control as well. So now here's the fun part, some of our videos. So what a session typically looks like, if it's a first session for DMI, the practitioner will conduct a brief assessment at the start of the session. Exercises that are chosen will depend on the child's presentation, their needs, their primary impairments determined throughout the assessment. Exercises can be performed on the tabletop or the floor, or even a combination of both, depending on the child's abilities and their needs. So I'm gonna play. This is a clip of, I chose 1 to 2 reps of each exercise, but they're typically performed 5 times. I shortened it just so we didn't have a 45-minute video. So I'll kind of talk a little bit about what's going on here. The child's wearing the Theratog garment, what Erin kind of talked about with strapping for his specific postural alignment needs. This first exercise is an example of using the anti-slip hold to complete a transitional movement into sitting. And then we'll see, we're kind of working a little bit on the floor. So this stuff can be done on the table as well, but he's just a taller kid, so we're doing it on the floor. Working on, and then here you see the pink, which is the slippy or organza. It was used in a standing balance exercise for the therapist to be able to provide counterbalance so the child can experience verticality with distal support. And then as you can see, this child required 2-person assist to complete some exercises to maintain that postural alignment. The tabletop exercises are typically used to focus on head control, trunk control, rolling, sitting, transitions into sitting, crawling, dynamic seated and standing balance, and some transitions into standing and supported standing. So the goal here for the tabletop exercises is to promote improved head and trunk control, weight bearing through the upper and or lower extremities, riding reactions, dynamic trunk alignment, trunk extension, and weight shifting. So here in this video, it's focusing on head and trunk control. And as you see, the child's challenged by trying to find midline with her trunk and her head. And she has to control everything above where my hands are, so where the therapist's hands are. And you can see by the end, she gains control of her head and keeps it in midline. And that's the exact goal for this exercise. So she did amazing. We'll go to the next one. Okay, so our floor exercises is where we are going to be bringing in to do more of our obstacle courses. So all of those wooden pieces that Erin was talking about before. So the floor exercises are going to focus more on standing transitions, supported stepping, obstacle course navigation, and dynamic standing balance, kind of as you saw in that first video of him on the organza. Floor exercises increase weight bearing through the lower extremities. They increase dynamic trunk alignment, endurance, coordination, dynamic balance reactions, and overall stability in standing. So this first exercise here is focusing on pelvic stability. He also has the Theratog garment worn on his lower half. And in this exercise, his left limb has to maintain balance while the right limb is moving. I am doing the work of the right limb because I really want him to focus on maintaining stability through that left side. Yep. And this is called, we like to call this one the pizza. So we're delivering pizzas. And this next exercise is focusing on targeted stepping with support at his stance limb. So he has to work on initiating steps and foot placement while I am providing support through his stance limb. The tube is placed in the middle for visual and tactile cue for foot placement. And it's a great exercise for kids that scissor their gait when they're walking.
Okay. So we'll talk a little bit about our home exercise program. So whether a child is doing weekly therapy or doing our intensive, we like to provide families with an HEP. Home exercise programs should be completed daily to promote new connections, to dominate over incorrect pathways. Implementation of HEP improves overall outcomes. And families are provided with that HEP, which, especially if they're an intensive family, we always record and practice with the families before leaving at the end of an intensive. If it's a kiddo who's local and comes weekly, we often have the parent check in and see if they have any questions with their home exercise program. As mentioned before, we use that set of boxes. However, not every family wants to have a set of wooden boxes in their home. So therefore, we often utilize other equipment that you can easily get off of Amazon, such as bucket steps, BOSUs, tilt boards, and step stools. And we are providing families with exercises that they will be most successful with at home. So we also don't, for example, the exercise that Kaitlyn did on the tabletop, she was kind of floating the child in space. Probably not an exercise we're gonna expect the parent to do, and we understand that. So we want families to be most successful and feel confident with any exercises that we have them complete at home. So we would choose a different exercise for that child, for their family, when it comes to their HEP. So we'll talk a little bit about training. So as mentioned before, you do need to be an OT or a PT to be trained. There are 3 introductory levels, A, B, and C, 2 intermediate levels, which are A and B, and then you can also be a teacher. You can also go to dmitherapy.com to locate a list of therapists. There are virtual and in-person trainings. The higher level courses must be done in person. However, the intro level courses can be taken virtually. When a training is performed, therapists learn the theories, the tenets of practice, so some of the things that you guys learned today, just in a little bit more detail. They perform dexterity tests, and they are taught a set of exercises, generally 30 to 35 for the intro level exercises. That include head control exercises, sitting transitions, rolling, exercises for getting onto hands and knees, creeping, army crawling, standing transitions, and then some of the obstacle course navigation exercises, such as the one that Kaitlyn showed with the boy, where she was stepping with him at his legs. They learn the exercises, they practice on dolls, and then we have demos who come in so that they are to make sure that they're performing the exercises safely with those kids, and then they're able to practice with their patients. And that concludes all of the information we're providing you all. Do you have any questions for us?
I have a question for you. So my child is fed by a G-tube, but we are working on oral feeding with him. You had mentioned that you've seen outcomes from DMI with those areas. How does that work, I guess? Because it seems to me like you're doing a lot of like balancing, muscular things. So how would that help him with feeding orally?
I mean, part of it would depend if it's more like sensory, so we'd have to tease out the sensory component of it. However, because we are working so much on all the postural muscles, when we see increases in trunk strength, sometimes that if there's kind of more of an oromotor or postural control issue that might be kind of limiting some of our feeding skills, that might help better support those feeding skills.
So more like the muscular features of swallowing and those sorts of things.
Yes.
Okay.
So we do have some kids that will come for, maybe they want to do a feeding intensive. We often also suggest that they do a physical hour with a PT or an OT, whether it's DMI or a different modality, just so that they're also getting that sensory information in addition to strengthening their postural muscles for feeding.
Okay.
So actually my daughter is starting NAPA on Monday. I just wanted to ask, I know that you do sort of like I'll say an assessment before you start the intensive. What do you look out for to kind of do like the timetable for what you're going to work on during the day for her, basically? What would be the drivers that you would do in this assessment to kind of determine, oh, maybe we'll work on this today or we'll work on that tomorrow? She does have the timetable. She's doing maybe DMI from 8 to 9, PT 9 to 10. But what I'm guessing, what I'm asking is that what actually determines what you'll be doing with her during that session, basically? What would be the
Yeah.
driver? Is it just what she shows to you?
So we take into, first time we work with your child, we want to hear from you what your family's goals are, and then we put that in conjunction with what we're noticing, like what we identify as the biggest impairments. And then the different treatment hours might look different. So for DMI, for example, it might look different because we are trying to provide as much novelty as possible. So we're probably going to change exercises up a lot. And then we also might look at like how their arousal level might change day to day. Maybe one day we're a little bit sleepier. Sometimes the Wednesday of the first week of their intensive, it can be a little bit tougher. They've worked hard for a couple days. So we might choose exercises that include more like inversion of their head so that they're getting more vestibular input. Or that might be a day that we choose to use the vibration plate that we talked about before. So you might see a little bit more variety when it comes to DMI. For the other hour, if they're doing suit or a traditional OT or PT hour, they try to do a little bit more motor repetition. So those exercises might look a little bit more structured the same based on what the therapist determined would be the best set of exercises based on your goals and child presentation on the first day. And then they'll grade those up or grade them down, kind of
So
depending.
if something's not working, you can like just change quickly to something, try something else.
Absolutely.
Yep. And then also they will all communicate. So like we're not all going to be doing, unless the child needs to work on like the same exercise that many times, but we'll kind of communicate. So like we're not all working on the same thing. We're all kind of collaboratively working and targeting the different impairment areas.
We're excited.
Excited to have you.
I have a question. And I know every case is different. In a DMI experience, what is like a standard, I guess like the actual DMI therapy is like time frame? Is it like weeks? Is it every day for a week, or is it multiple weeks? Like days of activity and rest? What does that look like? You know, in a standard world, I know everything is.
We generally like DMI to be done within an intensive model. So our different therapy practices have different, what their intensives are look a little bit different, but generally we like to do it 1, 2, or 3 weeks. At Napa, we do generally 3-week intensives. We do offer some 1-weekers throughout the year. There are some therapists that offer 2-week intensives. Oftentimes, those therapists might do 2 45 or 50-minute sessions at Napa based on what other hours the child might be getting. Generally, the kids will have DMI once or twice a day. Maybe if they're a little bit younger, they might get DMI once in the morning, once in the afternoon. If they're a little bit older, maybe they're also we offer suit therapy and some other modalities, so maybe they do 1 hour of DMI and 2 hours of the suit, so they're only getting, because they might have 4 hours in a day, so we only do DMI with them maybe 1 hour of those 4 hours. So it does depend on the patient age, fatigue level, again, their goals, things like that, but DMI generally is done within an intensive model of therapy. We do have some kids who are local who do intensives, and then they also might get DMI once a week as on a traditional basis, but generally they do supplement with intensives a couple times a year.
I was just going to say, I don't know how much Ruby is now doing DMI. I feel like y'all kind of...
We're doing like a combo.
Yeah, that's what I
a hybrid
remember.
session, yeah.
But Ruby's been doing DMI with Napa since 2020. And I just feel like with her brain injury, that repetition and like when you talked about the novel like situations, I'm like, she used to, when she would fall, was always going to hit her head, like no matter what. And I feel like through DMI and those movements where you like pull things out from under her has really helped her to be safe when she's like trying to walk. And I've just seen so much improvement. And honestly, DMI even helped us pick the school model that we chose, because y'all talk so much about neuroplasticity and the repetition and like the repetitive movements of DMI. We picked a classical school that does a lot of repetition and memory work and sensory things with that memory work just to help continue that. And so I feel like it's really laid a great foundation for Ruby's like rehab and growth, and we've just seen so much. The only time she really has injuries now is when the thing that she goes to like braced herself on is not there. Like, you know, like she went for the door frame and just barely missed, or one hand missed, and so we've been really grateful for like what we've seen through DMI.
So you mentioned something about, like, I think she mentioned going like every week and stuff. My son did the NAPA in Los Angeles, and it's like a lottery to even get into the DMI, and it's impossible. So do you have, and so he did get it, and we saw wonderful things with that, but how, I'm sure in order to fully reap the benefits of the whole, you would need to do it weekly and the repetitions and all that. I know you said something about like Amazon, you can get stuff like at home on Amazon that we can do realistically at home. Is there like a list or anything where you have that we can access that? And number two, are there programs, does NAPA have programs where you can go like every week? Like you don't have to have this wait list to, like this impossible wait list, so that if we do believe in DMI, that our son can actually continue to do it on a more weekly basis, I guess?
There are weekly sessions. What that looks like at each individual clinic is going to be a little bit different in terms of their weekly wait list. So there's the intensives, and then there's also the weekly sessions. My suggestion would be to get or chat with, you're Los Angeles based?
Yeah, Los Angeles.
I would chat with the scheduler in the Los Angeles clinic and just let them know that you're really interested in doing weekly DMIs. So that could be with an OT or a PT. So if they don't have an open session with an OT or PT trained in DMI available right now, then at least you could get on the wait list for both OT and PT for traditionals. I would just specify that you want to do traditionals with them.
Oh, okay. That's what you do. Okay, in Austin. Oh, in Austin. Okay, and then at home, so you said that they can use stuff like toys that you can get on Amazon, like.
Oftentimes, if you did an intensive, based on what the home exercise program that they provided with your child, if there were more like of the obstacle course type navigation, that's where I'll usually suggest to the family, like, bucket steps. Instead of using a box, you can use bucket steps, or you can use books kind of piled up if you don't have any, like a step or something at home. We don't have a list necessarily, but that would be a good idea to kind of have a list of
Our social media team.
of equipment. Yeah, that's a great idea. That's something that will.
Because I know I follow on Instagram the NAPA, and I know sometimes they'll have other kiddos in a reel, and it'll have like an example of a therapy that they did, and they'll use something that we can do at home. So it gives the idea, my son's also working on that. Let me do that with the pipe cleaner or whatever.
Yeah.
So that would be helpful, to have like a.
That's a great idea. You could put that on the list too. No, that's a great idea. We should definitely, talk to our social media people. Any other questions?
So it seems like everything's like limb-based. Do you guys do anything with like facial muscles or anything like that at all, or no?
Oh, that is a good question. Not anything facial muscle specific. Did you have anything specifically in mind?
Like tongue movement or smiling or frowning or?
Not necessarily in DMI. Sometimes our speech therapists will work, or they'll use kinesio tape in different ways to kind of facilitate or inhibit certain facial muscles, but not specific to DMI that I can think of.
More head control, like supporting at like the top of the head or like at the chin and their napes, kind of stuff like that, and less about like the facial muscles.
I think that's
Well, thank you.
Thank you so much. We appreciate it.